Welcome back to the 12 Days in March video podcast edition. This material was delivered as a live lecture at the University of Massachusetts Medical School. In this edition, we focus on the key features of lithogenesis that you will need to know for the USMLE Step 1 exam. Now we're moving over to the conjugated category. Remember this little game we played before, is it conjugated or unconjugated? Well, we know this is conjugated, right? And so that puts us in this category here, extrahepatic versus intrahepatic. From the lab point of view, both intrahepatic and extrahepatic kind of behave the same way. Conjugated bilirubin, elevated alk phos, and compare and contrast that with the chronic liver diseases, which are considered transaminase predominant. They may have hyperbilirubinemia, but they also have marked hepatic injury. All right, so here we are, back to the stones. 4Fs, female, fat, fertile, 40. It really just has to do with estrogen predisposing to stone formation, estrogen causing increased cholesterol. Right upper quadrant pain after a fatty meal. And, it seems very rudimentary, but again, when they're telling you right upper quadrant or pain radiating to the right shoulder, it's not what it is, it's what it's not. That's their way of saying they don't have pancreatitis. Mid-epigastric, if they tell you it's mid-epigastric pain, well, then that's not gallbladder pain, that's something else, ulcer or pancreatitis. So pain to the right upper, in the right upper quadrant or radiating to the shoulder, transmitted by which nerve? Yeah, the phrenic nerve, diaphragmatic irritation, phrenic nerve as opposed to the intercostals, given pleuritic chest pain, focal, so phrenic nerve to the right shoulder. That's very specific language, and we already talked about bile salts, phospholipids, cholesterol. We talked about bilirubin and pigment stones, and so we're going to talk also about the tests, so lithogenesis and the tests. People understand ultrasound, they understand the films, HIDA-scan. I'm not so sure that people understand well, so we'll focus on that. Anyhow, pathogenesis, supersaturation of bile, that's really what you got to know. It's supersaturation with what? It's really cholesterol. This crystal formation entrapment, that's nice. They're not going to ask you. It's not that important for our purposes. The idea of stasis, so acalculous cholecystitis, that question sneaks in periodically, and it's going to be, everything is going to sound like cholecystitis, and it's going to be in a patient with starvation, namely on TPN. That's where you're going to see an acalculous cholecystitis question. So it's going to be the same as cholecystitis, there's just not going to be any stone. All right, so supersaturation, this is an ugly diagram. Do pay attention, and just, it's actually really easy if you don't be stubborn like me. So here's cholesterol, higher cholesterol, more stones. Here's bile, more bile, less stones. Here's lecithin phospholipids, more phospholipids, less stones. So do be familiar with this idea, this kind of triangle, this curve, as it relates to supersaturation. So when you're over here with lots of bile, lots of phospholipids, no cholesterol, that's a happy zone, right? No stones there. Be prepared to identify that zone. And look, I'm sticking this in as a question. Remember, you're getting credit for this. A, B, or C, the least lithogenic area. The reason I'm doing this is I really just want to make sure everybody gets this concept. So just everybody put the right answer in, please. Okay, the people who took this one over here with a small amount of bile, low bile, it's high phospholipid, but low bile, that's not the least lithogenic area. It's high bile, high phospholipid. It's A. That's what I'm telling you. You got to be comfortable with this little triangle, but I think you guys are messing with me. So let's keep going. And the reason I got this little biliary mycele is just to kind of give you a pictorial of what's going on with these stones. Here you have cholesterol in the middle, and phospholipids are the black and bile are the white. And you see this is like a big old happy cholesterolnitis, and we're not really going to get stones there. But look what happens here. If you don't have enough bile salt because of the reasons we already discussed, obstruction, no enterohepatic circulation, no terminal ileum, so now you have more cholesterol, less bile, and it predisposes to stone. You wind up with these stones, and that's unhappy here in the lithogenic region because you don't have a lot of bile. Okay? And the reason I want to continue to use this idea of the biliary mycele in terms of this balance for stone formation is because there's a treatment. Ursodeoxycholic acid, essentially you're giving a bile acid orally, and so it's bile salt actually, and it supersaturates the cholesterol. So now you have a lot of bile out of proportion to cholesterol. So this is medical management of cholesterol stones. It's an uncommon question, but it's a fair question on a medication. Patient has gallstones, doesn't want to go to surgery. What are your treatment options? This is your only treatment option. So here's kind of a little bit more summary.
So these are, right now, this is cholesterol stones. So the type of stones, cholesterol mixed, the majority are actually mixed, but cholesterol or pigment, it's very binary on the boards. You're either going to get a cholesterol or a pigment stone. The cholesterol stones happen from increased cholesterol, i.e. estrogen, or disruption in the processes we talked about. The liver's not making bile, it's not secreting it, or you're not reabsorbing it. Okay, we've beaten that to death. So the pigment stones, besides being associated with hemolysis, the key thing there to be familiar with the name, calcium bilirubinate. Bilirubinate, that's easy. Calcium, the calcified. These are radiopaque stones. So the patient with hemolysis has calcification in the right upper quadrant on a plain film. That's a pigment stone. Diagnosis, Murphy sign, people are familiar with that. Ultrasound, CT. Ultrasound, you can see stones, CT, see stones, but HIDA scan, the reason I want to emphasize HIDA scan is because it's actually a functional study. It tells you how bile is actually flowing through the ducts. So it's a radioactive tracer that's taken up by the liver, concentrated in the gallbladder, over time, secreted into the intestine. So it's like a stress test for the gallbladder. And then when it comes to gallstones, everything is about location, location, location. Those are the questions they're going to ask you about. All right, so here we go. We're back live. But you got to interpret the lab. So we have hepatocellular damage, no particular pattern. AST is a little higher. It doesn't matter. It's not 2-to-1. Alk phos is involved, and you have conjugated hyperbilirubinemia. So you need something that is damaging and obstructing the duct. And your choice really is cystic duct. And we already said cystic duct just hurts the gallbladder. It doesn't hurt the liver. So it's beyond the cystic duct. The hepatic duct, well, if you block one duct, the rest of the liver is doing okay. So you may get elevated alk phos, but you rarely would get such elevated transaminase abnormality. Okay, so when you have transaminases that high, it's not hepatic duct, it's common bile duct. That's where the stone is, and it's never the duodenal papilla unless they're giving you amylase and lipase. Okay, so let's do HIDA. Again, taken up by the liver, concentrated in the gallbladder, secreted in the common bile duct, 15 to 20 minutes, and ultimately in the intestine. So that's a patent cystic duct because it has to go from the liver, intrahepatic ducts, in through the cystic duct. That's how it works. That's why we do the HIDA. We want to know that the cystic duct is patent. Here's somebody with appropriate symptoms. So acute cholecystitis, acute upper quadrant pain. Again, you're not always clear that this is cholecystitis. HIDA scan, you give it. You see it coming down the bile duct. It's in the small bowel. It never made into the gallbladder. The cystic duct was obstructed. So that's a positive HIDA scan for cholecystitis. You can use it for acute or chronic cholecystitis. And compare and contrast that with ultrasound. So ultrasound can tell you there's a stone, but the presence of a stone doesn't make right upper quadrant pain cholecystitis, a stone alone, because stones are common. So the HIDA tells you if they're functionally relevant. Now, that's HIDA versus ultrasound, generically speaking. The ultrasound do have features suggestive of cholecystitis, like Murphy sign, wall thickening, pericholocystic fluid. So I'm not dissing ultrasound, but on the boards, the way they're going to use ultrasound versus HIDA, just be forewarned. And again, here's the gallstone ileus. They may ask you where it lodges, the ileum, and we already talked about pneumobilia. All right, here are the pigmented stones, calcium, bilirubinate. So a question, who was pigmented stone? Didn't know that the hell that's what it was called. Calcium bilirubinate, radio opaque. Now we're getting a little bit away from stones, but with the gallbladder. This porcelain gallbladder, everybody has some awareness of it, but come test day, when they actually ask the question, you got to do the math. So thickened, calcified gallbladder wall puts you at risk for adenocarcinoma of the gallbladder, not cholangiocarcinoma of the ducts. It's adenocarcinoma of the gallbladder. If you see a calcified wall of a gallbladder, generally you want to take that gallbladder out. Look what I did. All right, while you're all getting the correct answer on that one, let me again just underscore that there are certain images you're going to need to be familiar with, so you're going to have some vague familiarity where the gallbladder is located. And even if you can't quite make out the gallbladder, you got this rim of calcification. That ain't the aorta. The aorta belongs over here. Not much is going to get calcification like that in the right upper quadrant. Be prepared to identify a calcified gallbladder and know the association. This one was a scattergram. We didn't do so good. So again, we're still worried about acute cholecystitis, and on this one, it's that notion. An abdominal X-ray shows opacities in the right subcostal. They didn't call it upper quadrant, subcostal area. What's causing a radio-opaque stone? So we're looking something with calcium, and the calcium stones are the calcium biliruminate ones. They're the ones associated with hemolysis. So in this instance, elliptocytosis, like spherocytosis, has low-grade chronic hemolysis present. That is the only one associated with radio-opaque stones. People didn't like that. We didn't actually score well on that, and I don't know if we didn't do the math on elliptocytosis as a form of chronic hemolysis. A problem with the cytoskeleton deformability. Those cells are taken up and hemolyzed extravascularly, splenic macrophage.
And we conclude this podcast on bile metabolism as related to cholelithiasis. Be sure to recognize hemolysis in all its forms as related to the development of pigment stones. Thank you.